Hello, my name is Curtis Crane of Brownstein & Crane Surgical Services, and today I'm doing a video informed consent on metoidioplasty. Metoidioplasty is a Greek word. Meta means toward, oideo means male genitalia, and plasty is plasty. So it's a Greek word meaning towards male genitalia that was made up to describe this procedure. Metoidioplasty is a really creative, interesting procedure that has a variety of forms. The simplest metoidioplasty is called a simple meta, and that's when a phallus is created that has no urethra, there's no scrotum, there's no vaginectomy. It's simply creating a phallus. You can also have a meta with urethral lengthening, but without a scrotum and without a vaginectomy. So that would allow a patient to possibly stand to urinate, although that is not a guarantee in meta, and I will discuss that momentarily. A patient can have a simple meta with a scrotum. A patient can have a simple meta with a vaginectomy. The Cadillac of metoidioplasty would be a meta with urethral lengthening, with a scrotum, and with a vaginectomy. A patient can take each individual component of releasing, creating a phallus, having a scrotum or not, having a urethral lengthening or not, or having a vaginectomy or not, and mix and match. So this comes down to a conversation between you and your surgeon to figure out what is going to make you the happiest. How are we going to maximize benefit and minimize risk? Meta is also an interesting procedure because the result is highly dependent on two things: the patient's individual anatomy that you come to us with, and the patient's body habitus, or BMI. Is the patient of ideal body weight, or is the patient obese? This will greatly affect the outcome in a meta. If a patient has had significant growth on testosterone or has gained a lot of growth through pumping or DHT cream, which never hurts. I get asked questions all the time. Should I pump or should I use DHT cream? My advice is always try it if you want. And some patient gives a great result, and some patients it's mediocre, but it never hurts. If a patient comes to us with a lot of growth on testosterone and they are as close as possible to ideal body weight, they typically can stand to urinate with a meta, although this is not a guarantee. There is a learning curve to standing to urinate. In some patients, it does take practice. It takes time for the swelling to go down from the original surgery. Now, if situations aren't ideal, say a patient hasn't had much growth on testosterone, this decreases the chances that a patient will be able to hygienically stand to urinate, meaning they can pull the phallus out of their fly and comfortably stand to urinate at a urinal and not worry about showering their khaki pants with urine in front of them. If a patient doesn't have much growth on testosterone and is obese, this further decreases the chances that a patient will be able to successfully stand to urinate after their metoidioplasty. The erectile tissue is anchored to the skeleton, the erectile tissue in the meta. And so if you picture this is the skeleton and this is the erectile tissue of the meta, the subcutaneous fat defines where the skin is. So say the skin is here. This makes the meta or the phallus this long, and this is the same in cis men. If a patient loses 20 pounds, then all of a sudden the skin goes from being here back to here, and we just gained 20% of length in our phallus. If a patient gains 100 pounds, then all of a sudden there's more subcutaneous fat and the skin is out here and barely any of the meta comes out. The surrounding fat swallows up the metoidioplasty. This makes it less likely that a patient will be able to clear their fly, past the subcutaneous fat and skin of their body, past their fly, and be able to hygienically void. It's unknown how well each patient will do with the urethral lengthening and a metoidioplasty. There's a learning curve to standing to urinate with a meta. And I urge all patients to start by standing to urinate in the shower. There's going to be swelling with surgery, so the urine will always spray for the first month, 2 months, possibly 3 months. A surgeon going in to perform a metoidioplasty never knows how far we can stretch the erectile tissue and the nerves to maximize the length created in a meta. The erectile bodies should never be cut, because then the patient will not have natural erections, and that's why some patients are choosing metoidioplasty. The nerves should never be cut to increase the length of the meta, because then you won't have sensation in the phallus or at the tip. So a surgeon will never know until he or she gets in there to perform the meta how long the erectile bodies and nerves are. We can only give estimates. If you're concerned about how much length you have or how much subcutaneous fat you have, you may want to fly to visit your surgeon, or at least send pictures so the surgeon can say, it's likely you'll be able to urinate with a meta, or it's unlikely, maybe you should include phalloplasty. So what I just went over were the benefits of metoidioplasty: possibly standing to urinate, although it's not a guarantee; the ability to have a phallus, although it will probably be a 1 inch to 3 inch phallus, a 4 to 7 centimeter phallus with the girth of about my thumb, although this is highly dependent on each individual patient's anatomy; the possibility of having a scrotum, having a vaginectomy. This is a genital gender confirmation surgery. Alternatives to treatment include not having any surgery at all, or having a phalloplasty. If you're someone that hasn't had much growth on testosterone, or you're more subcutaneous fat in the area, making it less likely for you to hygienically stand to urinate, then you may consider phalloplasty, which is taking tissue from the forearm, back, or thigh, a different site, harvesting tissue, bringing it to the position of the of the phallus, and creating a 4, 5, 6, possibly 7.5 inch phallus that isn't dependent on how much growth you've had on testosterone or your body habitus. So now that we've explained the possible benefits, the alternatives to surgery, I'd now like to talk to you about the risks of surgery. The risks of surgery include infection, bleeding, wound healing complications, derangement of nerve supply, altering sensation. During the vaginectomy, if you choose to have one, there's a risk of injury to the urethra, the bladder, or the rectum. If you choose to have a urethral lengthening, there's a risk of urethral stricture, which is scar tissue building up in the urethra, urethral fistula, which is a connection from the inside of the urethra to the outside skin, so that when you urinate, not only does it come out the tip, but it comes out the base of the phallus, the scrotum, behind the scrotum. The risk of necrosis or tissue loss, scarring, the inability to predict the final aesthetic outcome, length and girth of your meta, spraying of urine or urine trapping. I will now go back and talk in more depth about each individual risk. So the risk of infection, bleeding, and wound healing complications, I'd say these risks are all less than 5% in my hands doing a metoidioplasty. We do practice sterile technique. You will have IV antibiotics during the surgery. You won't need IV antibiotics or oral antibiotics after the surgery. And with this, my risk is probably less than 3% risk of infection. The risk of bleeding, I've never transfused anyone blood after a metoidioplasty. Occasionally there's significant bruising If you do have an infection or a hematoma, meaning a contained blood collection, in some cases this can increase the risk of wound healing complications or cause tissue necrosis, loss of some tissue, typically in the scrotum. I've seen this in less than 3% of patients. That risk is higher if you get an infection, if you're diabetic, if you're on steroids. Anytime we make incisions to build a scrotum, to create a urethra, nerves are cut. There are microscopic nerves everywhere that you can't even see with an operating microscope. I stay far away from the nerves that are important to give sensation to the head of the phallus, the base of the phallus, but there is a risk of derangement of nerves. The risk is higher in areas directly behind the scrotum, possibly along the suture line of the scrotum. Every patient having a urethral lengthening will get a suprapubic tube. There is a risk of pain at that suprapubic tube site. Typically that pain goes away once the suprapubic tube is out. Pain is a risk with any surgery. Every patient having a meta will have anywhere from a few days to a week to a few weeks, even to a few months of pain. There's a small risk, less than 1%, of chronic pain after a metoidioplasty. If that happens, we may need to put a patient on Neurontin or gabapentin or different nerve pain medications. If a patient is having a urethral lengthening, there's a risk of urethral stricture. That's scar tissue building up in the urethra. So say I build a urethra, the diameter of this pin, but as you heal, you narrow down to a tiny little pinhole. I'd say this risk is less than 5% in my hands with metoidioplasty. If you find that you used to urinate and finish in about 2 or 3 minutes, but now it's taking you 4, 5, 6 minutes to finish urinating, you may be developing a urethral stricture. You should probably call me or call your local urologist or call both so that you can get checked out. If it is taking you 4, 5, 6 minutes to finish urinating and you have a urethral stricture, you probably need another surgery to correct it. That other surgery would require a suprapubic tube placement for about 2 weeks while it heals. Some surgeons may put in a urethral catheter. My preference is a suprapubic tube. There's also a risk of urethral fistula. That risk is anywhere from 5 to 10% with metoidioplasty. A fistula is a connection from inside the urethra to the outside skin, so that when you urinate, instead of the urine just coming out the tip, it also comes out the base, the ventral or bottom suture line of the phallus, from behind the scrotum or the scrotum itself. Fortunately, the majority of these heal on their own. We should always wait approximately 3 months to see if it does. If your fistula has not healed by 3 months, it likely won't. In which case, we should go back and repair the fistula. I personally like to wait until a patient is 4 to 6 months out from the original surgery to repair the fistula. If the fistula is repaired earlier than that, at 2 or 3 months, there's a lower likelihood that the fistula repair will be successful because that tissue is not done healing. There's a lot of inflammation. The tissue is firmer. If a surgeon waits 4 to 6 months, the fistula repair success rate is closer to 90%. I tend to like to operate when we have a higher risk of success than trying to rush in and repair something too early. And just like a urethral stricture repair, if someone has a urethral fistula repair, I place a suprapubic tube. Anywhere where we cut, patients heal with a scar. Just like in chest surgery, sometimes patients heal with an imperceptible scar. Sometimes the scarring is more significant, leading to a hypertrophic scar or even a keloid. I haven't seen keloids or hypertrophic scars in my meta patients. Just because you form a keloid in your chest or from a surgery on your back or on the earlobes, it's common to have a keloid. Doesn't mean you're going to keloid everywhere. The risk of having keloids around the genitalia is lower. Keloids don't tend to form there as badly. But scarring is definitely a risk wherever an incision is made. Genitalia are like beautiful and unique snowflakes. Patients come to us with all different sizes, shapes, and outcomes from testosterone in their genitalia. So it's very difficult to predict the final aesthetic outcome, the appearance, the length, the girth of the metoidioplasty. This is heavily dependent on your body habitus and what you start with and how you heal. None of those things am I in control of. If you look at my website, there's plenty of pictures of metoidioplasty on there. That a relatively similar technique was used for each of those, yet there's a very different outcome. There's a risk of spraying with urinating after your metoidioplasty, whether you have the urethral lengthening or not. The tissue around the urethra is swollen, and just like if you have a garden hose and you squeeze the garden hose tightly, the water coming from the garden hose will spray. The urethra is the same way. This spraying can continue for anywhere from 1 to 3 months or possibly a little longer. I urge patients to practice urinating in the shower as they're learning to stand to urinate if you have a urethral lengthening with your meta. There is a learning curve to standing to urinate. I've seen plenty of patients that have a great outcome, possibly 6-7 centimeters of phallic length on their meta, their ideal body weight, but it takes them a few weeks or months to get standing to urinate down. There is a learning curve, so just keep after it. There's also a risk of trapping of urine. The anatomy of a female urethra is, here's the bladder, and then the urethra is relatively short and comes out and goes straight down. When a urethral lengthening is pursued as a gender confirmation surgery, the urethra becomes about 3, possibly 4 or 5 times longer. It comes out, it goes down, and then it comes back up. There's a dependent portion of the urethra, dependent meaning gravity, keeps that urine there at the very end of the bladder contraction. Some urine stays there. You see men in restrooms, cis men, trans men, pushing up behind the scrotum, pushing on the scrotum, milking out the urethra to try to get the last few drops of urine out of that urethra. In my lifetime of standing to urinate from ages 3 to right now that I'm 42, I'm just used to walking away and a few more drops of urine falling out in my pants. That's very much a male pattern avoiding. I remember in grade school, nursery rhymes saying, you can bang it against the wall, you can shake it with your hand. I think it's you can shake it with your hand, you can bang against the wall, but in your pants, the last drop is sure to fall. You have to have wall and fall line up or it doesn't rhyme as well. Regardless, the point is, urine can trap. There's dependent portions of the urethra, and unless you milk that urethra out, I shouldn't even say unless, you should expect that some drops will fall as you walk away. With healing, some parts of the urethra may be a little more dilated than others. Certainly more urine can trap in those areas. So it's definitely something to think about and consider. So just to review, metoidioplasty, the final result is very dependent on how much growth you've had on testosterone and how much body fat you have specifically in that area around where we're creating the meta. You should discuss with your surgeon your own body habitus. Possibly if standing to urinate is extremely important to you and you haven't had much growth and you have a little more subcutaneous fat there, phalloplasty might be a better alternative. Other risks include infection, bleeding, wound healing complications, tissue necrosis, urethral stricture, fistula, pain at a suprapubic tube site. With vaginectomy, there's risk of damage to the urethra, the bladder, or the rectum. There's a risk of scarring. There's an inability to to predict your final length or girth or aesthetic outcome. Patients commonly have, especially while healing, spraying of urine at the tip or trapping of urine. None of this list of complications is meant to scare you. It's to educate you. Metoidioplasty is a wonderful procedure that I'm an international expert at performing. Everyone in my practices that I have trained, we get very good results, and our complication rates are lower than international averages that have been published. Any surgeon performing metoidioplasty for you should go over these commonly known complications that, that any patient should be educated on. I appreciate your time. Thank you very much.